Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to present Professor Navneet Singh, who many of you already know from all his works with the guidelines and staging committees around the world. You may know that Professor Singh was a co-chair of the ASCO guidelines for the management of stage 3 non-small cell lung cancer, and it's a great delight for me to allow Professor Singh to present on the management of stage 3 guidelines based on the new ASCO recommendations. Navneet, over to you.
Thank you, Professor Lev, and thank you for inviting me to speak on management of stage 3 lung cancer. This is my customary slide. I have no conflicts of interest to disclose. However, I would like to state that no AI help has been used for making this presentation, and it's not strictly a summary of all available evidence, and has also some personal viewpoints, and it's also not intended to be a substitute for clinical judgment for individual case management. And I'm going to try and split it up into these headings: determining resectability and unresectability, and the importance of accurate staging, the optimal treatment of resectable stage 3 non-small cell lung cancer, neoadjuvant versus adjuvant versus perioperative treatment, the optimal treatment of unresectable stage 3 disease, and finally, the molecular determinants of treatment decisions, which I'll intersperse with the above two. Now, one needs to know that the TNM staging system has been used for both non-small cell lung cancer and small cell, although small cell has been traditionally staged as extensive stage and limited stage. And since the topic was of stage 3 lung cancer, one has to be familiar that stage 3 disease typically is small cell limited stage. Accurate stage is of paramount importance. And if we want to make an oversimplified statement, survival is directly proportional to stage. So if you look here, whether you have the 7th, 8th, or the 9th TNM editions, or whether it is clinical staging or pathological staging, the survival curves are quite widely separated from stage 1A to stage 4. And in fact, survival goes down drastically from being above 90% at 5 years for stage 1A1 to almost 0% for stage 4B. And stage 3, which is the focus of our discussion today, also varies widely, with being around 36% for 3A versus 13% for stage 3C, and a similar difference for pathological staging. Unfortunately, in our setting, most patients present with advanced disease, which is 3B, 3C, and 4, and the percentage of patients in whom you can actually attempt a curative intent treatment is quite small, less than 4% for 1 and 2, and approximately 13% for stage 3A. And even at our national level, the story is quite the same. Approximately 45% have distant metastasis, another 35% or so have loco-regional disease, and a localized only disease is only on 15% or so. If you come to this chart, which you are all familiar with about the 8 TNM stage groupings, you can see that anything which is to the left and the top of this line is perhaps clearly resectable. Anything which is to the right of this line is in all likelihood unresectable. And what falls in between these two could go either way. However, the entire crux of the matter is whether this is accurate or not, because accurate staging also implies accurate treatment decisions. And therefore, you would be able to identify potentially resectable disease, underdo surgical resection, and even have potentially curative intent treatment and saving lives. Now, there are some practical points to staging, and that is that in a significant proportion of cases, imaging cannot replace invasive staging procedures. And so these 3 circles, which are one inside the other. So you can see that the first outer layer is based on imaging, which is CT or PET. Then you have the minimal invasive staging, and the inner circle is of surgical staging. Now, endoscopic methods are preferred as the initial interventional procedure for mediastinal staging, and therefore there is a concept of endoscopic staging, which is EUS plus EBUS TBNA, which is now called as medical mediastinoscopy. And you have even a single scope concept of doing EBUS TBNA and a EUS BFNA with the same scope. Now, I would like to highlight that sometimes it is very difficult to accurately stage. Just to give an example, this was a 53 years old gentleman whom we had clinically staged as T4N1M03A. Now, this was thought of being as T4 because of a 5 centimeter mass in the left upper lobe and a nodule in the left lower lobe. And he underwent surgical resection, which was a left upper lobe lobectomy and a wide excision of the left lower lobe superior segment nodule, as well as a systematic mediastinal lymph node dissection. And when you looked at the gross report of pathological specimen, it seemed to indicate nothing unusual, and it was a typical adenocarcinoma. But if you looked at the microscopic picture, there were tumor cells which were positive for CK7 and TTF1 and suggestive of adenocarcinoma. But in addition, there were multiple granulomas with central necrosis, and the stain for acid-fast bacilli was positive. In fact, the left lower lobe nodule showed only confluent granulomas, necrosis, and AFB smear, and there was no tumor in the left lower lobe. And therefore, the final diagnosis was actually a pathological 2A, T2B to be precise, and no other adverse prognostic factors based on the pathological staging. And tuberculosis was the only thing in the left lower lobe nodule. So giving an overview, once you have confirmed the diagnosis, accurately staged the disease, the treatment depends upon histology and whether you have small cell or non-small cell. Small cell is still, as of now, simple, although there have been recent advances. Limited stage is chemoradiation, followed by consolidation durvalumab and PCI based on the Adriatic trial. For extensive disease, you have chemotherapy with an immune checkpoint inhibitor and followed by maintenance with the immune checkpoint inhibitor. One thing to highlight is that for stage 1 to 2 small cell, one should still attempt to get surgical resection. For non-small cell lung cancer, the treatment is going to depend upon the stage of the disease. Stages 1 to 3A are where you are going to attempt surgical resection, and that could be either surgery upfront followed by an adjuvant systemic therapy, chemo, immune checkpoint inhibitor, or a tyrosine kinase inhibitor, or neoadjuvant chemoimmunotherapy followed by surgery, and then with or without adjuvant immune checkpoint inhibitor treatment. For stage 3B and C, which is not resectable, and even bulky multinodal stage 3A, it is concurrent or sequential chemoradiation followed by consolidation durvalumab. For metastatic disease, the treatment is still determined by the histological subtype, and I'll not go into the details here. 2 or 3 things to remember. One should avoid immune checkpoint inhibitor treatment for EGFR and ALK positive non-small cell lung cancer. It doesn't work and only adds to cost and toxicity. For these patients, EGFR and ALK inhibitors, which is osimertinib and alectinib as of now, are the preferred adjuvant treatments. And for unresectable disease after chemoradiation, osimertinib should be used as consolidation treatment and not durvalumab. Now, stage 3 is also the disease which has the most heterogeneity, and it ranges from a clinically occult end-to disease at one end to overt mediastinal infiltration on the other end. And this is reflected in both performance status and the tumor burden difference for this spectrum. And you can have treatment based on giving surgery at one end versus only chemoradiation on the other hand. These are 4 trials which were published in the last 2 or 3 years, which have revolutionized the management of potentially resectable lung cancer: the CheckMate 816, Keynote 671, AGN, and the CheckMate 77T. And this is just a summary of all the four trials, as well as the adjuvant-only trial of Empower 010. And I won't go into the details. The thing to highlight is that this also included approximately 35 to 40% patients who were PD-L1 negative, except in the Empower 010 trial, which had to have PD-L1 positivity. In the 816, it was nivolumab plus chemotherapy for 3 cycles, followed by surgical resection. In the perioperative trials, it was 4 cycles of the immunotherapy agent with chemotherapy, followed by surgery, and then adjuvant treatment with the immune checkpoint inhibitor for anywhere from 9 months to 1 year. And the adjuvant-only trial used atezolizumab for 1 year. Now, if you look at the neoadjuvant only trial or the perioperative trials, they have very striking hazards ratio for event-free survival to the tune of 0.6 or so, and pathological complete response ranging from 18% to 25%. Important thing to note is that approximately 20% of patients in all of these trials after randomization did not undergo surgical resection. Now, the whole intent of having more effective therapies is that at the end of your treatment, you should be able to get responses like this, which is pathological complete response and no adverse prognostic factors. And the overall survival with neoadjuvant nivolumab and chemotherapy, the Checkmate 816, has just been presented at this ASCO and published in the New England Journal of Medicine. A very impressive 5-year overall survival rate, an increase of 10%, vis-a-vis the increase of 5% with adjuvant chemotherapy alone historically, and even a 10% increase in the lung cancer specific survival at 5 years. Now, the benefits were more pronounced for PD-L1 expressors compared to non-expressors if there was a pathological complete response, and if pre-surgery or post-treatment there was clearance of ctDNA. However, one needs to remember that for EGFR and ALK positive, the approach is different. So this was the ADAURA trial, which was published 5 years back, followed by its update on overall survival. And here patients were randomized into either osimertinib or placebo after surgical resection with or without adjuvant chemotherapy. And this was the impressive overall survival for patients with stage 2 and 3A disease. As you can see, that the overall survival hazard ratio was 0.49, with approximately 12% increase in 5-year survival. But if you break it down into based on stage group, you can see that the benefits were most pronounced for stage 3A, where there was an 18% increase at survival at 5 years. And the magnitude was much less for stage 1B and 2. And that's why the hazard ratio was most impressive for stage 3A disease. Similarly, alectinib in resected ALK positive NSCLC, this was published last year in the New England Journal of Medicine. And this was a slightly different study design from the ADAURA, in which patients were randomized to alectinib or platinum-based adjuvant chemotherapy. Now, here again, the results were very impressive, with the hazard ratio of 0.24 for disease recurrence or death, and adverse events were significantly lower with the targeted drug as compared to chemotherapy, representing a new standard of care for ALK positive disease. A little bit about unresectable locally advanced disease. And so there's always a debate of whether to do concurrent or sequential. Concurrent chemoradiation is the standard of care if patients are fit for that. And this should be followed by consolidation durvalumab if there is no EGFR or ALK based on the Pacific trial. And again, you can see a significant difference in median overall survival and a 10% difference in 5-year OS rate and a 15% difference in 4 years PFS rate. However, even if patients are not eligible for concurrent, they should still be given durvalumab consolidation after sequential therapy, as the Pacific 6 trial told, where the median PFS was an impressive 13 months and OS 39 months. As I said earlier, osimertinib is the preferred consolidation treatment after chemoradiation if an EGFR mutation is present based on the LAURA trial, and here durvalumab should not be used. The benefits of this are even more striking than with durvalumab. And as you can see, a PFS of 39 months versus 5.6 months, a hazard ratio of 0.16, and a 50% difference in 12-month PFS rate. Now, clearly, there has been a need for more effective therapies, and use of immuno and targeted therapies for molecularly selected patients has led to improvement in clinically relevant endpoints. And we started with this car, which was introduced several decades back, and everybody thought it was great. But we know now that this is what everybody who wants to drive would want to drive. And so although they have 4 road wheels and 1 steering wheel as common, yet there is a difference. However, since everything revolves around biomarker testing, what is the global scenario? And so this was the ISLC 2024 survey on biomarker testing. It had almost 1,700 responses all across the globe and all disciplines included. But the important thing was that only 63% of respondents believed it to be important for late stage, and only 30% or so believed it to be important for early stage. So clearly, Houston, we have a problem here. And to bring it into perspective, the EGFR and ALK prevalence in parts of Asia is pretty high. In our setting, EGFR and ALK prevalence is almost 26% and 10%. And if you look at the enriched population of never smokers, females, this goes way up to almost 40% and 16%. Finally, I'd like to touch upon what is a controversial topic. What is resectable non-small cell lung cancer? Traditionally, we have known this to have no evidence of extra or intrathoracic metastasis, ruling out N3 disease, N2 disease being not bulky or multi-station, and the primary lesion being amenable to an R0 resection. However, in real world, there can be very challenging situations. We had a 52-year-old never smoker lady in whom a 4.5 by 4 centimeter left upper lobe mass was picked up, and the endobronchial biopsy confirmed it as adenocarcinoma. A PET CT for staging detected this to be 6 by 5.8 centimeters and extending into the left hilum with an ill-defined interface with the left pulmonary artery, staging it as T4N1M03A. We started her on pemetrexed cisplatin, and a reflex molecular testing showed this to be EGFR exon deletion positive. So extrapolating data from the metastatic setting, we added gefitinib to chemotherapy, asked for a surgical opinion after 2 cycles, and he gave an opinion that you do 3 more cycles and then he would reassess. She tolerated treatment very well. After 5 cycles, there was a significant response. The surgeon felt that even though there was an ill-defined interface with the left pulmonary artery, he would be able to have a R0 resection. So she underwent a thoracotomy, a left upper lobe lobectomy, along with the sleeve resection of the left pulmonary artery and a systematic lymph node dissection. And the final stage was a grade 2 invasive adenocarcinoma, YP2AN01B. And she was started on adjuvant osimertinib based on the ADAURA trial, and she's close to 3 years now on follow-up and doing perfectly fine. So one could argue that this definition in today's era of highly effective neoadjuvant and adjuvant therapies could be revised to no evidence of widespread metastasis by imaging and cytological or histopathological sampling, ruling out N3 disease by imaging and endoscopic or surgical sampling, N2 disease being not bulky or multi-station either upfront or after neoadjuvant therapy, and the primary lesion deemed to be amenable to R0 resection either upfront or after neoadjuvant therapy. And this trial has just been published in JAMA Oncology, where they looked at using neoadjuvant immune checkpoint inhibitors with chemotherapy for borderline resectable and unresectable stage 3 disease, included T4 patients, included N3 disease, and 75% underwent surgical resection with a PathCR rate of 29% and a median EFS for all patients who underwent surgical resection being 53 months. So clearly, this may be the way forward. So to summarize, stage 3 is the most heterogeneous amongst all non-small cell lung cancer stage groups. Accurate staging is a key factor in determining treatment outcomes, including the feasibility of surgical resection and eventually clinical outcomes. Neoadjuvant chemoimmunotherapy is now firmly established as the standard of care for potentially resectable stage 3 disease without EGFR and ALK. And osimertinib and alectinib are the preferred adjuvant treatment options for such patients who have undergone surgical resection. Chemoradiation, preferably concurrent, followed by consolidation durvalumab, is the standard of care for unresectable stage 3 disease without EGFR and ALK, and osimertinib is the preferred consolidation treatment for patients with EGFR mutations in this setting. However, access and affordability to immune checkpoint inhibitors, as well as most targeted drugs, remains a challenge for routine implementation in low and middle income group countries. Thank you very much.
Thank you for an amazing overview. It's great to hear from you directly, especially with regards to your work on the ASCO guidelines. Can I ask, Navneet, one of the most interesting things I read in the ASCO guidelines was that one of the statements where you mentioned that in general, patients should not be excluded from surgery by non-surgeons. That's quite a good generic statement. How did that come about, just out of interest?
So the basis for all, I mean, as I said, stage 3 is the most heterogeneous group, and it requires multidisciplinary inputs and decision on whether the patient has to have a surgical approach or a non-surgical approach. And based on our experience, as well as inputs from the surgeons who were part of the group, the clear answer was that the decision to operate or not operate has to be by a surgeon and not by a non-surgeon, not by a medical oncologist, not by a radiation oncologist, except in the scenarios where you have overt mediastinal infiltration, involvement of great vessels, and so on. But in other cases, which are even borderline, it should be surgeons whose input is very crucial.
Thank you very much. From the inference from the guidelines, you mentioned that patients who are deemed resectable should receive upfront chemoimmunotherapy. And then later on the guidelines, you mentioned that only if you don't receive upfront chemoimmunotherapy, then you should be considered for adjuvant chemoimmunotherapy. From this, I infer that the preference would be upfront neoadjuvant treatment. Is that correct?
So you would break this down based upon the stage and nodal disease. So stage 1B probably does not need neoadjuvant therapy, and you can directly take them up for surgical resection. Anytime you have nodal disease, and that would indicate almost all patients with stage 3, majority of them, and a significant proportion of patients with stage 2, they should definitely get neoadjuvant therapy, whether that is chemotherapy or chemoimmunotherapy based upon the molecular testing. And the decision to do adjuvant therapy would again depend upon the final surgical staging, the presence or absence of adverse additional prognostic factors, which we know are in vogue today, the presence or absence of lymphovascular invasion, spread through air spaces, or STAS as we know it, perineural invasion, and so on. So, I mean, it cannot be a generalized statement, but yes, if you take out stage 1B disease, then most of the patients should get neoadjuvant chemo or chemoimmunotherapy upfront.
Thank you. On one of your slides, you mentioned that multi-station N2 would be considered unresectable, but most, if not all, of the studies for chemoimmunotherapy included multi-station N2 just by the virtue of non-exclusion. So how does those two statements, figure out?
Right. So the all of this, as I said, those 5 things which I listed about unresectability are based on traditional assessment methods before the era of immunotherapy. Now we know that the addition of chemo to immuno really makes a big difference in downstaging, and therefore, as I said earlier, currently simply multi N2 disease or even perhaps not too bulky N2 disease would qualify for enrollment. Well, you will have debates whether nodes more than 2.5 centimeters should get enrolled or not. But my personal belief is that yes, in the absence of overt mediastinal infiltration or nodal disease, which is conglomerate one, they should be given the benefit of neoadjuvant chemo IO.
And also coming back to the point, you've already alluded to in one of your final slides, the potential for downstaging or induction treatment. So formerly, it was already very muddy between resectable and non-resectable, and now there's an additional layer of consideration, which is unresectable at the outset, then downstaged. Currently, the license indication are for resectable at the outset. How do you think this is going to affect the guidelines going forward with the downstaging from unresectable to resectable after neoadjuvant treatment?
Right. So I think this was only a phase 2 trial. It'll probably require a phase 3 trial if that ever happens. I don't know if it would or not. I assume at some point you would have that data. But referring to the case which I showed, we actually used an approach which has now been presented and published as the new ADAURA approach for EGFR positive disease this ASCO. So based upon your molecular profiling, you would either end up using chemoimmunotherapy or perhaps an EGFR inhibitor with chemotherapy. And once you do that, the ability for the surgeon to go ahead and achieve an R0 resection is going to be much better than what was traditionally there without these targeted or immunotherapies. I assume the guidelines would factor into this, and even if they're not able to come up with a class 1 evidence, they would still come up with something like a consensus recommendation or an expert opinion that yes, even patients who are quote unquote borderline should not be denied the benefit if they are otherwise fit for undergoing surgical resection.
That'll be an amazing step change in the progress and also consideration in this area of disease. It's a field that, as we were discussing earlier, is moving so fast. It's a question from the audience from Dr. Kara Mustafaglu, who's asking about if there is a role for mediastinal restaging after neoadjuvant systemic therapy.
Yeah, that's a good question. And so there is a school of thought that if you have persistent nodal disease at the end of your best therapy, which would be a neoadjuvant chemoimmunotherapy, or if you have done a neoad or of a EGFR positive, if you still have persistent nodal disease, then you could abandon the surgical approach and go ahead with a concurrent chemoradiation followed by the consolidation EGFR inhibitor or immunotherapy based on the molecular profile. But I think the last word on that has still to be said. There is still going to be a lot of debate amongst both medical oncologists as well as surgeons whether to take up such patients or not, because the outcomes for persistent nodal disease after initial or induction therapy are not as great as people who are cleared. The thing which might help would be looking at ctDNA clearance. So if ctDNA clearance has been achieved, you could argue to go forward and consider surgery. But if ctDNA clearance was not achieved and there was persistent nodal disease, then probably they may not benefit from surgical resection.
Yeah, but none of the trials actually excluded or even looked at persistent N2 disease. So such recommendations, again, wouldn't be consistent with the clinical trial pathways?
Correct. So mediastinal restaging was never a mandatory part for any of these trials, and it was left to the clinical discretion of taking them forward or not. So there's, as I said, it is still something which can be hotly debated.
Yeah, I mean, stage 3 is an amazing stage. It's like there's so much evidence, there's so much opinions, it's multidisciplinary. So it's always been a fascinating area of mine. As always, there are always too many questions for us to be able to answer in our short span of time, which remains me to thank you so much, Navneet, for an amazing presentation. Next week, it's really exciting. We're going to have Dr. Puneet Iyengar from the Memorial Sloan Kettering, and you might know about the LU002 trial, widely anticipated oligometastatic trial, which did not demonstrate improvement in overall survival, and to hear it from the principal investigator himself. All this brought to you thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Once again, Navneet, thank you so much for being here and discussing with us, and also all the leadership work that you do to guide our specialty forward. Thank you. Bye-bye.